All right, hello everyone and welcome. Today, we're going to do a deep dive into a bacterium that I'm sure is familiar to all of you, but one that has a really fascinating and, let's be honest, often frustrating story, Klebsiella oxytoca. Because what makes this bug so interesting is that its clinical story is really a tale of two very different personalities. So here's the central puzzle, right? How can one single organism act like your typical run-of-the-mill multi-drug-resistant hospital pathogen in one patient, and then in another cause this severe bloody colitis that's driven by its own inherent toxins? It's these two completely distinct clinical personalities that we're going to break down today. And hey, just a quick heads up on our sources. This entire overview was put together using a Gemini deep search. If you want to dig into the papers and research yourself, the complete list is right there for you in the accompanying notebook document. Okay, so let's start where it all begins for us, right at the bench. Identification. Properly pinpointing Klebsiella oxytoca is, of course, the first critical step, and luckily, it comes down to a few classic bread-and-butter microbiology characteristics. So let's quickly run through its profile. You know the drill. It's your classic gram-negative rod. It's non-motile and it's often encapsulated, which gives us those super mucoid colonies you see on blood agar. And on McConkey, no surprise, it's a very enthusiastic lactose fermenter, giving us those bright pink colonies. At this point, it looks just like any other typical Klebsiella. But this is where the story gets specific. How do we tell it apart from its much more famous cousin, Klebsiella pneumoniae? Well, while there are other tests, the real workhorse, the single most important differentiator for any busy clinical lab, is the Indole test. Klebsiella oxytoca is Indole positive. That simple classic biochemical reaction is our number one flag. So let's dive into that first personality, the one we run into most often in the hospital. This is Klebsiella oxytoca, the opportunist, the nosocomial pathogen, a very familiar and challenging foe. And in this role, its rap sheet looks almost identical to Klebsiella pneumonia. We see it causing catheter-associated UTIs, ventilator-associated pneumonia, some really nasty bacteremias, and of course, surgical site infections. It really preys on the most vulnerable patients, those who are immunocompromised, critically ill, or have indwelling devices. And what's the biggest challenge when it's playing this part? It's all about acquired resistance. This isn't about what the bug is born with. It's about the dangerous genes it picks up from its neighbors, usually on plasmids. We're talking genes that code for ESBLs and, even more concerning, carbapentamases. This is what's really driving treatment failure in these hospital-acquired infections. Okay, so now for the pivot. Let's talk about its other personality, which is far more unique and specific. This is where we see Klebsiella oxytoca not just as an opportunist, but as a pathobiont, the direct cause of antibiotic-associated hemorrhagic colitis, where the threat literally comes from within. AAHC is a really dramatic clinical picture. You have a patient who suddenly develops bloody diarrhea and severe cramps, usually right after they've been on a course of antibiotics, often something really common like a penicillin. And it's so important to remember this isn't C. difficile. AAHC is a totally distinct syndrome, and the one and only culprit is a cytotoxin-producing strain of Klebsiella oxytoca. So how in the world does this happen? Well, the pathogenesis is a perfect, almost textbook two-hit model. First, an antibiotic, say amoxicillin, just wipes out the normal, healthy gut flora. This creates a vacuum. Second, the intrinsically resistant Klebsiella oxytoca is left completely untouched. With no competition, it's free to overgrow to huge numbers. And once it's dominant, it starts turning out cytotoxins that directly attack the colon lining, causing that hemorrhagic colitis. We basically turn a harmless commensal into a pathogen with our own intervention. And this slide, this just perfectly sums up the whole story, doesn't it? On one hand, you have intrinsic resistance. The chromosomally encoded BLA-OXI beta-lactamase is a predictable, species-specific trait. It's the key factor that allows AHC to happen. On the other hand, you have acquired resistance, the plasmid-mediated ESBLs and carbapentamases. These are variable, they're unpredictable, and they're the number one reason for treatment failure and hospital infections. Two totally different mechanisms, two totally different clinical stories. So, keeping these two very different personalities in mind, how do we actually approach treatment and control? Well, the strategy has to be able to handle both scenarios, and it has to be guided by really smart diagnostics and, of course, robust infection prevention. You know, the foundation for any good treatment plan is solid antimicrobial susceptibility testing. Here we're looking at the EU CAST breakpoints for Enterobacterales, which we apply to Klebsiella oxytoca. Having these standardized MICs is just absolutely crucial. They give us that clear, evidence-based line in the sand between an antibiotic that will work and one that's likely to fail. Now, when we're up against that nosocomial personality, especially the ESBL producers, international guidelines are pretty clear. For simple cystitis, sure, an oral option like nitrofurantoin might work if the isolate is susceptible. But for anything more serious, we're talking pyelonephritis or systemic infections, the carbapenems like meropenem are the undisputed big guns. They're the backbone of therapy.
And if we look at a specific example, like the Dutch SWAB guidelines for urosepsis, we see a really key stewardship principle in action. They recommend starting empirically with a broad agent like ceftriaxone, but, and this is the important part, with the strict requirement to de-escalate to a narrower, more targeted drug as soon as those susceptibility results come back. It's all about hitting hard at first and then hitting smart.
And what about for kids? Well, the principles are exactly the same, but the execution has to be incredibly precise. Dosing is everything. It's calculated strictly on a milligram per kilogram basis. For AAHC, management is simple and the same as adults. You stop the offending antibiotic. For other infections, like a febrile UTI, agents like ceftriaxone are common, but the dose is always tailored specifically to that child's weight. But at the end of the day, prevention is really our most powerful weapon, isn't it? The core principles are just non-negotiable, starting with relentless, absolute hand hygiene. For any multi-drug resistant strains, contact precautions are a must. You combine that with rigorous environmental cleaning, aseptic device management, and strong antimicrobial stewardship, and that is our best defense against both spreading this bug in the hospital and creating the conditions for HHC. Okay, so this all brings us to one last, really important thought. Where do we go from here? Because the dual nature of this organism presents a really unique challenge for surveillance and for our diagnostics going forward. And this quote, this just nails it. For most infections we see, the most critical question isn't, is it Klebsiella oxytoca? The question is, does it have an ESBL? Does it have a carbapenemase? The resistance mechanism is what dictates therapy. But in that one unique case of AAHC, the species identity itself is the entire story. So its name matters profoundly, but only sometimes. So this leaves all of us with a big question for the future, right? As resistance continues to evolve at this crazy pace, how can we, in the lab, improve our rapid diagnostics? How do we get to a point where we can quickly identify not just the bug, but also distinguish its acquired mobile resistance threats from its intrinsic pathogenic potential? That's really the challenge that lies ahead of us. And that's our deep dive into the two faces of Klebsiella oxytoca. If you found this useful, please do subscribe to the channel. We really, really value the expertise in this community, so please share your own feedback and your insights in the comments below. Thanks so much for watching.